My name is Alex, and this is my project on developing a prognostic model for palliative cancer care patients using available clinical pathological variables. So, what is prognostication? Prognostication is the process of predicting future medical outcomes, namely survival, based on our current knowledge. Its accuracy is extremely important in tailoring treatment length, treatment aggressiveness, conserving resources, improving clinician confidence, and overall increasing the quality of care that we're distributing. The population of patients that we'll be focusing on in this study are palliative cancer care patients, which is a division of cancer care focused on symptom control and improving patient quality of life. This is a graph of the Alberta survival estimates within palliative cancer care. As you can see, there's a clear discrepancy between those overestimated and those correct or underestimated. This is largely due to the subjectivity of the prognostic process and that it involves a lot of clinician prediction. Clinicians attempt to answer questions such as how long do you think the patient will live? Would you be surprised if a patient died in this amount of time? And what is the likelihood that a patient will live past a certain time frame? Each of these are subject to their own individual clinician biases or misjudgments. Recently, however, there's an opportunity for patient data to improve the prognostic process. Scores and algorithms such as the Palliative Performance Index, Palliative Prognostic Score, and Palliative Performance Scale have all been derived from the electronic medical record data and in an attempt to improve the accuracy of these prognostications. Notably, however, there hasn't been great success with this, and there's no consistently reliable and accurate prognostic model or score used in practice today, and the accuracy of these prognostic models drastically decreases the closer we are to the end of a patient's life, which is when most palliative care occurs. So this leads us to our research question. Are palliative radiotherapy patients able to be prognosticated accurately for overall survival with the available clinical pathological variables? And clinical pathological variables are just data points and certain patient characteristics that are available to oncologists upon a patient presenting. There are four main steps to our methodology: data collection, statistical analysis, model creation, and model validation. Firstly, we had to collect variables and patient data from the ARIA radiation oncology information records. We collected data on 367 patients from the Calgary, Edmonton, Grand Prairie, Lethbridge, Medicine Hat, and Red Deer zones, and combined this with radiotherapy treatment data from the Cancer Registry and other studies. We collected ourselves variables such as the patient performance status, cancer types, certain metastases, what treatments the patients were currently on, height, weight, and certain blood work values, including hemoglobin and lymphocyte percentage. The median survival of our population was 175 days. We then had to analyze this data set with a Cox regression analysis to determine the significance of each of these variables. We used a p-value of less than 0.05 and also derived the hazard ratio for the statistically significant variables. From there, we paired non-statistically significant variables from our model for efficiency and created a novel risk score calculation from the parameter estimates in our analysis. We then had to validate this new calculation in our own independent cohort. So 57 separate patients had their data extracted and were tested against their actual data to see if our model could predict accurately. This is the Kaplan-Meier curve for our final novel risk score. Our risk scores range from 0 to 33 based on the presenting characteristics of a patient. Notably, we have four clear delineations between each of the categories, and our accuracies are above 0.7, which is the threshold we are trying to reach as an indicator of a good predictor or a good statistical model. So this was extremely encouraging to us. And we also found that we improved on clinician prediction of survival alone with an accuracy of 0.685 and the palliative prognostic score, which was used as a reference estimate, which only had an accuracy of 0.534. So in conclusion, we've identified several significant prognostic factors. These were the ECOG status, hepatic metastases, systemic therapy, hospitalization, and clinician prediction of survival within a patient. These are factors to look out for within clinical practice and can be used to formulate specific recommendations or to be included in future prognostic models. We've also created a translatable, accurate prognostic tool for palliative cancer care, which can improve the quality of care that we're distributing to patients and also improve the resource efficiency of our hospitals and our healthcare system. And we've also proved the concept where we've indicated that there's potential for similar models or more specific models to prognosticate within this area. And it's a step towards revolutionizing the prognostic process and ensuring that we're consistently delivering accurate treatments. I'd like to take a moment to acknowledge Dr. Mark Kerba, Dr. Stosky, Dr. Gautam, Dr. Ghosh, and Dr. Beatrice Garcia Diaz for all of their help with putting this project together. Thank you for listening.